It's always a pleasure to come on Doc Plexus. Today we'll be talking of the trends, latest trends in public health, and a lot of public health came in the limelight after the pandemic. And the complexity of public health, I have tried to compare it with the game of chess. In fact, it is more complicated than a game of chess. If we take the black pieces as the emerging health threats and the white pieces as the advances of medical technology, there is an exponential rise in both the sides. In fact, chess mein there are 32 pieces, or 8 2 are 32, 8 to 32. There are 32 pieces, 16 black and 16 white. They are fixed. The moves are fixed. But the public health, new technologies are coming, new pathogens are emerging, or new pathogens are being discovered. So we are having much more on a plate than a game of chess. And the approach to public health has to be different than the approach to clinical medicine. And as brought out in this pandemic, a clinician sees just he or she plays with one piece, that is his specialty. Whereas a public health person has to consider all the pieces on the whole board. So this would be the theme of the session today. What are the advances in medical technology, the white pieces? There, in every subject, every discipline of medicine, there are the rapid advances, and the science is going very fast. Unfortunately, the art is being left behind because there is no one to coordinate these advances. The science is getting fragmented in different disciplines. So we require in public health a coherent view where to combine all these disciplines and use the advances to the best advantage. Then there are advances in social sciences, sociology, and health economics. Because of the technological advances, the healthcare is becoming costlier both at the individual level as well as the societal level, community level. No government can afford the healthcare, the advanced technology for all the population. So we have to prioritize. Then there are social changes. Though sociology is also changing, the social changes, the community is changing, the family structure is changing. Gradually, the industrialization is coming from a cohesive rural community. We have more urban communities, nuclear families. So that brings its own health challenges. And advances in public health engineering, water treatment, and sanitation also have to be used to the full potential. Advances in other fields, as you are all aware, health informatics, AI is coming up, genomics, artificial intelligence. These are the challenges which are sometimes very, very disturbing. Sometimes it takes up, sometimes makes people uncomfortable, but we have to garner its advantages and take care of if any disadvantages, if any. So these are the chess pieces. As I said, there are more pieces on the board. Societal changes. Social media has also come. We have seen in this pandemic, social media, not only in all walks of life, whether it is politics, whether it is health, social media is influencing a lot of here. Sometimes it is creating panic. Sometimes it is misinformation. Demographic trends, the aging population. We are also going rapidly toward the aging population. Changes in lifestyle, sedentary lifestyle, lack of exercise, lack of healthy food, change in work environments. Like I am also sitting here and leading a sedentary life. So these all have a bearing on public health. Epidemiological transition and changes in disease profiles from more and more preventive and lifestyle associated disease are raising its head. And we will see that these lifestyle obesity and non-communicable diseases not only affects the chronic diseases but also acute infections. Like during the COVID pandemic, maximum mortality and morbidity were in people who are having comorbidities and obesity. So there is no clear-cut risk factor now. These risk factors of good health is important for both communicable as well as acute infections. Climate change is adding its own problems. Of course, that is a big issue, but even day to day, sometimes there is a change in vector behavior or people movement due to climate change, forestation, deforestation, economic growth leading to affluence and unhealthy lifestyle, global travel and migration from one end to the other end of the globe. Disease travels in no time. So that is also, it is becoming the chess. There is something called very fast chess. So earlier days there was a test cricket and slow chess. Now we have blitz, fast chess and T20. So those decisions have to made in real time. The public health is becoming very complex and you have to work under a lot of uncertainty. Misguided policy, poor public health infrastructure. This is something which we can take care of during the inter-pandemic periods. Like sometimes we are not seeing all the pieces on the board, and most biggest challenge is to improve, particularly in countries like India, or public health infrastructure. We subsequently will see. And middle class rapidly, as I said, demanding cost of healthcare, increasing middle class, unequal access and poor quality of healthcare. This is a big challenge which is going bigger by the day, because most of the tertiary care hospitals or even doctors are concentrated in urban areas and rural areas are being neglected. Antibiotic crisis, drug resistance is coming because of antibiotic misuse, antibiotic use in the veterinary. Mental health problems and drug addiction is again a major threat, which is a global threat now. Iceberg phenomena of diabetes and other non-communicable disease. By India is known as the diabetic capital. We have got a genetic handicap also. Geographical variation in disease behavior. We have seen in the pandemic, the northern hemisphere was affected more severely by the pandemic than the southern hemisphere. Therefore, rigid policies like one size fits all needs rethinking. And so does the proposed pandemic treaty. The WHO and the world policymakers, public health policymakers are thinking of one size fits all, one health, and but if we see the epidemiology and the disease behaving different in the northern hemisphere and southern hemisphere, we have to rethink whether, like a chess board, number of chess games are there, pieces are same, the boards are there, but each game is different. Each situation is different. Similarly, each country has got its own demography, its own climate, its own behavior. So we have to have a local decision-making power rather than having a central authority which is making the guidelines. This is my personal view. So this is, as I said, this is the chess became quite famous after Vishwanath Anand became world champion. We have got a maximum number of grandmasters nowadays. We have got chess prodigies. So this is Vishwanath Anand. So this public health also needs to become popular like chess. Chess was not very popular before Vishwanath Anand. And I think the COVID-19 is the Vishwanath Anand of public health, because after COVID-19, people have started taking interest in epidemiology and public health. So let us make full use of this and be better prepared for future pandemics. So this is a rapid chess. As I said, Vishwanath Anand was the master of rapid chess. Blitz, we have to make where the time is very limited. Normal game of chess lasts for 4 to 5 hours, one game, but in rapid chess, you have to make the moves very quickly within seconds. So in this moving dynamics of public health and changing social environment and medical advances, it is becoming like a blitz chess of public health decision making. Changing trends in public health very rapid and dynamic. Few governments can act fast enough to meet the public health challenges arising out of this. We have seen in the COVID pandemic, there was panic of the people, panic of the policymakers, and hasty decisions were taken without considering the local epidemiology and local chess boards. This is leading to a situation analogous to blitz chess. Rapid decisions have to be taken with incomplete information. But unfortunately, in the pandemic, even after information was available, we did not change our tactics. So in future pandemics, we should be better prepared. Each country should take its own decision based on regional demographics which affect disease course. We had a young population, we could have responded to the pandemic in a different way. So this is now we are in the time of artificial intelligence and health. Artificial intelligence made it's not a new phenomena. The first time a grandmaster and the world champion, in fact, this is Gary Kasparov. This is Gary Kasparov. He was a world champion. First time he was beaten, grandmaster. First time a chess grandmaster was beaten by a machine. Chess playing machine known as Deep Blue, manufactured by IBM in 1997. So as I said, there is a lot of parallels between public health and chess. Like chess, the artificial intelligence came in 1997. Now the artificial intelligence is on the verge of influencing of public health and even healthcare. So Deep Blue is a turning point in chess, and the artificial intelligence is something which is we have to contend with. Every few years, we are alarmed by outbreaks. So these are some of the things which ruffles the chessboard. SARS in 2002-3, that was SARS 1. Bird flu in 2005, swine flu in 2009, Ebola in 2014, Zika 2015, and the most recent was the COVID-19. Computers like Deep Blue analyze faster than humans informatics to identify public health threats in real times. Perhaps we may have use of artificial intelligence in the future to analyze or predict impending pandemics, where maybe we can have something like we have nowadays a geographical information system or Google Maps for traffic congestion. The traffic is congested, which shows us in real time. Probably we can have similar applications showing the footfalls in hospitals and health centers. If there is increasing footfall, there may be something unusual. So these are some of the fast thinking, loud thinking rather. AI and machine learning have the potential to promote predictive, preventive, personalized, and participatory medicine. So we can, artificial machine learning can improve the precision because each human individual is different. There are variations. A drug behaves differently in a different across different patients. So we can tailor-made, customize the treatment, and genetic engineering, prescription, precise prescription, and other things are in the air. So this is something like a chessboard. We have got health technology access on this side. We have got disease pattern. As I said, disease pattern are changing. Chess pieces do not change, but disease sometimes there is mutation or pathogen may change. We have got polio. These are the communicable diseases identified by polio and measles. There are non-communicable diseases. These are diabetes, a ticking bomb. This is a disease burden, total health inequity. The lack of equitable distribution of health services, the rural area are compromised. Then health technology. So with health technology, we can easily control, say, where we have got good tools like measles and polio can be controlled, but after some time, these are the end game. We have to deal with this. So let us see how it goes. So with that health technology, we have eliminated some some disease burden. We have reduced, and health technology we may eradicate, say, measles and polio. Again, it is difficult because during COVID, the measles vaccination suffered, so measles is surging. So it's an ongoing game, middle game. And then, as I said, from the night it became a camel. The disease pattern is changing, emerging and re-emerging disease, different patterns due to. So, as I said, this is some of the challenges. Then there is a transition of the disease patterns. Earlier, the leading years was communicable disease like respiratory tract infection, diarrheal disease. Now the number one is the ischemic heart disease and psychological unipolar depression. Road traffic accidents, increased transportation and road traffic, cerebral accidents, and low respiratory disease in 2020 was somewhere in the middle. This was, of course, projected. Then, of course, after the pandemic, probably this must have gone up a little. In fact, there was, we don't know how accurate was that we can attribute to actual, because most of the people who died of COVID had comorbidities. So it would be a challenge to actually give the cause of death. But respiratory infections are again making a comeback. But definitely, if you see the right side in 10 years, there is a whole paradigm shift in the non-communicable disease, accidents, and psychiatric illnesses are on the rise. So these are some of the latest trends in the public health disease patterns. Then what are the response we have, how we have responded, and where are the gaps? So early attempts at primary health care, essential drugs, WHO gave a list that all these essential drugs will be available. We have to, particularly countries like India, have to stress on maternal and child health. We have got a very bad statistics for maternal and child health. Or maternal mortality rate is around 100 per lakh childbirth, which is one of the highest in the world. 10 times more than developed countries. The deaths of mothers during childbirth. Similarly, our infant mortality rate is also very high, almost 20 per 1,000 births, and the child health is also very poor. We have got the one of the highest rate of under 5 child malnutrition. And under 5 child malnutrition can give rise to higher risk of chronic disease in later life. So hygiene and education, health education, voluntary community involvement, top-down management, management of growth, cheap and needy. These are some of the responses. And current concerns of primary health care are social health protection, like people go below the poverty line when they expend on medication. Out of pocket expenditure is very high in our country, almost 50 to 60%. Health for everyone, both risk and healthier lifestyle. Education is a major challenge. We are a middle class, which is increased obesity and non-communicable disease. Professionalism in appropriate technology, community driven, so guiding the growth of and the medical care is not cheap nowadays because the expectations have gone up and medical technology has gone up. Specialized hospitals, cost of treatment is higher, and so the government responded by Ayushman Bharat scheme. By 2017, Government of India Universal Health Coverage launched the bold and Ayushman Bharat scheme. This was actually a insurance policy components for delivery of primary by upgrading the 1.5 sub-centers and primary health centers to be known as health and wellness centers. We have a network in the rural areas of sub-centers and primary health centers. Primary health centers for 30,000 population, sub-center for 5,000 population. A doctor is there at the primary health center and other auxiliary workers are there. And they have been upgraded. Actually, they have just renamed it. Not much investment has been done. Some people trained in health education and lifestyle awareness campaigns. They have known as health and wellness centers have been convened health and National Health Protection Scheme. This is the world's largest public funded insurance scheme with a coverage of 5 lakh per family annually. So all families below poverty line are covered by public health insurance of 5 lakh. There are certain gaps in this because there is only covers the indoor hospital care and 50% are the impaneled hospitals are the corporate hospitals. So basically, it did not improve the public health infrastructure, which is the need of the hour because most of the corporate hospitals are in urban areas. So traveling from rural to urban, they are not adequate hospitals in the rural area. So this will be a challenge. This insurance may be just to tide over the crisis. Financial outlay was quite high, 70 to 100,000 crores. And the COVID-19 pandemic exposed the cracks in a public health infrastructure and showed that such schemes cannot be shortcuts to public health. Because until unless we have a good public health infrastructure, emergencies like pandemics cannot be coped up with. Now the lifestyle changes. This is Marie Antoinette, the Queen of France, just before the French Revolution. When the people asked her when the people complained to her that they do not have bread to eat, she said that if they do not have bread, let them eat cake. So it seems now the people today are following her advice. They are eating cake and they are putting on weight. Marie Antoinette advised the starving masses in 18th century to eat cake if they do not have bread. The poor are following this advice to the letter. Newly rich people, those who have got good income, surplus income, who have recently come into wealth, their food habits, they have nowadays in many countries, the blue collar workers with more income, they are not very much aware of the healthy food. So they are eating a high sugar diet, sugary drinks and cakes and pastries. Now in the school and colleges also the consumption of sugar is very high, birthday celebration and other things. Rich eat salad and hit the gym. The poor are going and cakes, hamburger and pizza. So that's why you should see the food chains in the developing countries are mushrooming very fast because this is the main market, but our population is becoming unhealthy. So something has to be done about this. This is the latest actually public health, as I said, just like the chess pieces, it cannot be considered in isolation. You have to see the social changes, the market forces and other things. Otherwise, our population will become healthy, as unhealthy as the Western countries, and the next pandemic will hit up like that. Not because we do not have vaccines, we do not have drugs. It will hit us because we do not have adequate public health infrastructure, we do not have adequate beds equitably distributed to urban rural areas, and our population are obese and having comorbidities. We have done studies, our department found 9% diabetes in rural areas also, and higher is non-communicable disease risk factors like central obesity and high BMI among the poor also. So there, next to the towns, the suburbs and the rural area adjacent to big cities are also becoming unhealthy because the market forces are penetrating there. Then changing face of malnutrition. We are having a double burden. We have got a child malnutrition and we are having an adult overnutrition. More than 2.1 billion are overweight compared to 850 million undernourished. Unfortunately, this 850 million, the majority are in developing countries like India. So the developing countries are having the richest people and the poorest people. So we have got a double whammy. Half of humankind will be overweight by 2030. As on today, in fact, the USA, in the Europe and USA, Western countries, including Brazil, fast-growing economy, 60% as on today of people are overweight. 60%. They have crossed the halfway mark. India, it is 25% of people are overweight. This is data is available in the public domain. Japan, being a rich country, having the highest, has controlled its weight very well because Japanese ritual, Japanese diet is very healthy. Japan, the overweight is just like Asian country, 20 to 25%. African countries, the overweight is again 20%, 20-25%. That's why in the pandemic, if you see the African and Asian countries were not, particularly Africa, they have less than 5% vaccination coverage, but COVID did not affect them severely. Because their overall overweight is the biggest driver of this pandemic, mortality and morbidity. And half of humankind is overweight. If you see India, it is 25% at present. Western countries, 60%. So you can imagine they are almost 2.5 to 3 times more overweight. And we are following their lifestyle and we are also going the same way. Famine and undernutrition combined killed 1 million people while obesity killed 3 million. If you see. So obesity is killing more. It can be said as a silent killer, and with it goes the deaths from communicable disease like COVID, which hit the people with obesity. Other trends which will affect public health practice are telemedicine and artificial intelligence. So they have got a lot of potential, but they have got a downside also. Telemedicine will be able, particularly the underserved areas. You can have a general practitioner there. He or she can send the images to the specialist in the big centers, any part of the world. We can get an opinion. Some procedures can also be guided from distance, but there are certain downsides also because in a remote area there may be less connectivity, less resolution. Then there are issues of privacy. There are issues of confidentiality, data leaks. Those issues are there. There are issues of medical legal problems. If suppose there is some mishap, who is accountable? Those are the problems. The other downside is that governments and spending, they may take it as a shortcut that rural areas may be only served with telemedicine, the public health infrastructure and the health centers will not develop. So we have to balance it. We should have telemedicine at the same time. Nothing can substitute for in-person doctor-patient rapport and doctor-patient relationship. Telemedicine can be good. At least something is better than nothing. Or it can augment already existing health sector. Some doctors should be there in the peripheral who can get the expert opinion. So definitely telemedicine can be a boon in the future. Artificial intelligence is again large data sets, data mining and deep learning have now many X-rays can be read better by machine than by radiologists. There is less inter-observer. Histopathology slides can be particularly in underserved area and remote area, particularly for screening, not for confirmation diagnosis, rapid screening. Dermatology, personalized medicine, artificial intelligence will have a role to play in the future. And as a public health practitioner, one should know how to use it optimally, not to be unduly dependent on it, not to go all blindly in love, but at the same time, use it judiciously to the full advantage. Diagnostic accuracy machine better than specialist doctors. These are in routine cases, but the outliers, some odd case will require the expertise, art, and accumulated experience of a competent doctor. So machine learning should not make the doctor skill atrophy, like we are putting on weight when we have automobiles. So it should not be a barrier to our development of our own intellectual. So future doctors should be careful about that. And we can post on research post saying something, as I said, something is better than nothing. So it has a role in resource. And to conclude, after I just concluding by the saying of Bertrand Russell. He was a mathematician, philosopher in the 1950s. I think he got a Nobel Prize in 1954. He was a Bertrand Russell philosopher. He got the Nobel Prize in literature. He was a writer, a thinker, and a mathematician. And what he said the Bertrand Russell statement is coming true. He said that there are three stages of conflicts in human life as humans evolved. The first conflict is against nature, man versus nature. That is the environment, the infections, the pandemics and all. These are the natural threats. Once humans conquer nature, man turns against man. Wars, violence, homicide. So that is, we had the Russia-USA Cold War. Now we are having the Ukraine war. So man has controlled nature. And if there is a pandemic disaster, all humans come together. Then once we conquer the enemy also, man becomes the own enemy. Man against self. What we are having now, people are getting bored. They have nothing to do. They have conquered nature. They have conquered infections. They have conquered vanquished the enemy. So they turn towards self-destructive behavior, that is overeating, lifestyle, drinking, addiction, narcotics, drug addiction, tobacco, misuse of alcohol. So we have arrived that way. But again, this I had given this type of talk in just before the pandemic, COVID-19 pandemic in 2019. I was just a month before the pandemic. I was in Malaysia giving a guest talk. I ended like this: कि now we have to deal with non-communicable and lifestyle diseases. And the moment I came back to India, we again came back to infections. That is, the pandemic broke out. So it is a cycle, keeps on going like this. It is a circle rather, because infections have come back again. And lastly, I have to how to prepare for the future pandemic. So I said, since public health learns from pandemics, this was a learning exercise. I have compared the public health. I started with chess. I am ending with cricket because both games have become popular. So lessons from cricket for future pandemics. Now there's a lot of talk of pandemics act. You should have a pandemic treaty and other things. But what I feel is that, like in chess, we should have a good position. We cannot play with one pieces. Similarly, in cricket, we should have a, say, if we take the example from cricket, to win a match in cricket, you should have a good field placement. And when you deal with health services and a future pandemic threat, we should have a good field placement. We should have the good placement of health centers and sub-centers all over the field, that is all over the country. Now we are having only close-in fielding. All the doctors and hospitals are in the urban area. Deep में नहीं है, तो boundaries वहाँ निकल रहे हैं हमारे. So presently health resources are inequitably distributed. And there is a great urban-rural difference and rich-poor difference also. Even in the urban areas, the poor do not have insurance, the poor do not have. So we should have a future pandemic. Even in this present pandemic, COVID-19 pandemic, the second wave, what happened? Because there were no available hospitals and health centers in rural areas, people crowded to the urban centers, and urban centers also panicked. And there was a lack of public health hospitals which could have adequate beds. So all the private hospitals, they have their own limitations. They are having too many specialists and super specialists who do not know how to handle normal infections and all. They only consent to their specialty. The science of medicine has got fragmented. The art has disappeared, because art means combining everything, like a chess player or like a good cricket captain. So we require a good field placement, and all the fielders should be in the sub-centers and equal number of fielders. Then make the cricket pitch should be reliable. You know, in cricket, the pitch matters. good public health infrastructure. Like the pitch is weak or any pandemic, any disease can become a pandemic. Daily we are losing 2,000 people from tuberculosis. We are losing 2,000 children due to malnutrition because we do not have a good pitch. Even a normal ball, average bowler is taking wickets. We are losing children from malnutrition. So we should have a good pitch, means good public health infrastructure. Then pitch also means obese people are vulnerable, undernourished are vulnerable. If a disease strikes, if a pandemic strikes, so if the pitch is weak, we will lose a large number of people. So we should have a good control of population level obesity and comorbidities. For that, we require the public health services. Then we require more all-rounders instead of specialists, bowlers and batsmen. Now all people are becoming, all doctors are becoming specialists and super specialists. So we require all-rounders who can treat the minor illnesses before they have to reach the specialist or before they have to reach the tertiary care center. We should have all-rounders at the primary health centers and the district hospitals who are the general physicians. Earlier we had general practitioners who could treat the minor infections before they become pandemics. So that all-rounder we require. Then we don't have to depend only on one bowler, that is vaccine or intervention. Like we are preparing that next pandemic, we have one side we have a new virus, other side we have a new vaccine, and there is a gap in between. So that is, we cannot depend on one bowler. Vaccine may be required as a judiciously to be used. You use your bowlers. A good cricket captain will use the bowlers very judiciously. He will not over bowl or under bowl. Similarly, we require, and for that we require all-rounders who see the routine cases in the community rather than just virus at one end, microbiology or genomic surveillance and the vaccine. Both are high-tech adventures. They require a lot of technology, a lot of investment, but lot of in between simple measures can prevent lot of pandemics going out of hand. And then we have to take decisions based on local conditions. Like in Africa, in Asia, the pandemic had least impact, but we had the harshest measures in our country, which was not warranted because in spite of that, 80-90% of our population got the infection. So we have to take decision. And when we did lockdown in all local conditions, we are already a very high dense country, crowded country. We increased the transmission. Whereas those people were vendors, they were working outside the transmission minimum. So we blindly imitated the Western countries. So in future pandemics, we have to take a local decision on local conditions. So this is some of the lessons, as I said, because the latest trend in public health, we are having latest emerging diseases or imagined diseases. Sometimes we are having advanced technology, but we have to also think the latest trend in our public health policy. We have to take a latest trend in our public health policy, which is not very encouraging. The way things are going, we are not using the regional epidemiology, the regional decision making, like a good cricket coach or good captain should see the pitch in that year, then decide which bowler to require, which batsman to play. So we cannot take something what is happening in the county cricket in UK, what is happening in Australia, and the same pitch in India. Similarly with disease and public health responses, it should be just like a game of cricket, similarly, or a game of chess. Each chess is same pieces, same board, but each game is different. You cannot have the same rules for all. So this is, I end here. I think this is what I wanted to convey, because this is the anatomy of say, and this is the physiology, how we act. So these are some of the references. Learning, machine learning, artificial intelligence, then public health challenges in new millennium, Ayushman Bharat. So these are some of the studies we have done in our field practice area, both urban and rural in our department, where we found emerging non-communicable disease risk factors and even diabetes in the rural areas also. And so anyway, these are some of the references. Thank you. I think I have finished here.
Thank you so much, Dr. Banerjee, for that wonderful presentation. It was absolutely wonderful listening to you. Very well presented, lot of takeaways for the audience. So we have a few questions from the audience. So with your permission, let's go on to the first question.
Yeah, sure.
So my first question to you is, what areas of public health research do you believe needs more attention and funding?
Yeah, very good question. In fact, last week only there was a workshop in AFMC, and this was one of the panel that what are the research required in emerging disease and research. As I said, what research nowadays are technology driven, cost driven. On one hand, we are discovering new viruses, new mutants, new years. On the other hand, we are discovering the vaccines. And in between, we are discovering a vector. I was saying the three V's. The research is concentrated on vector means like what is transmitting like bird flu, the poultry, that is the vector which transmits and virus and so we are concentrating only on these and I was saying in between there are the fill in the blanks. Like we require now we say that the topic was global warming and disease. So we are one of the concern is that the vectors, the mosquito, the insect, which they will increase due to warmth or due to change temperature, and they will increase the spread of disease. So I said we, as on today, by personal experience, there is no. For the past 2 years, at least I know there was no entomologist. That is the person who studies insects. Either in FMC or in the, we are not having people who are going for this entomology. There is an acute shortage of ground level workers. I said research here is lacking. We are doing high-tech research. We have to have research in entomologists, biologists, climate scientists. So these are the basic sciences. Everybody wants their children to become doctors or engineers. So we require biologists, basic sciences. In fact, when I was doing MD, I had on the staff who was a basic scientist. So we require basic scientist research in the fundamentals.
Thank you for that insightful answer. Moving on to the next question. So, my next question to you is how can public health professionals address health inequities that have been exacerbated by recent global events such as COVID-19 pandemic?
It is public health can only lobby because the decision maker, it's a decision policy, it impacts on policy. So the policy makers and the politicians, and they have to be driven by the public demand. So the doctors can only make the people, empower the people so that the demand of the political leaders, that there should be basic health services like primary health care, sub-center, health center. Because as on today, the people have they have overestimated the miracles of medicine. Miracles of medicine, they think the modern medicine and tertiary care hospitals are the health. The problem is they are not health, they are the failure of health. They are failure of primary and secondary prevention. So the people have to, the paradigm shift has to come from the people who lobby the politicians because now they are opening AIIMS in every state and every year they are opening. But that is the failure of, because it's too late by the time the cost of treatment increases. Like obesity can be controlled earlier, diabetes can be controlled earlier, hypertension can be controlled earlier. If they don't have hypertension screening, the person lands up with coronary artery disease or retinal failure or kidney failure because the hypertension was not controlled. That becomes us. So we require basic health services, and that is the answer.
Thank you for that wonderful answer. Moving on to the next question. My next question to you is what are the potential benefits and challenges of integrating digital health tools into public health practices?
That's very good. I mean, we have got a lot of potential there. Digital health tools, as I said, firstly, it can give us a warning of some unusual health event happening. Let us say footfalls in hospitals, like traffic congestion we know. So that can be helped. Then other digital tools is like you require sometimes the general practitioner in the health center. He or she would require an opinion. So he or she can send the images to a radiologist in the urban area. Similarly, for other, their methods are there where they can, the instruments, the reading can be read. So, and then of course the exchange of medical information, even right from medical students to the casualty physician, he or she can check up the clinical key and other things, information like earlier you had to carry textbooks, you didn't have the latest edition there. Here you can put the search words. So even as an individual practitioner, right up to the organizational level you can gather health intelligence and large data mining can be done to find out the trends, disease pattern, trends and predictions.
Thank you for that answer. Moving on to and this brings us to the end of this session. Thank you so much, Dr. Banerjee, for your time and effort in putting together this interesting session. To our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Until we see you again, take care and happy dog flexing. Thank you.
Thank you. Thank you, Siddharth. Thank you.